Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast. On this episode, I will review questions and answers about Cerebellopontine angle masses. A free downloadable study guide on this topic will be available on my website, theradiologyreview.com. Without further ado, let's get into the questions and answers for this episode. First question: what are the contents of the Cerebellopontine angle cistern? The Cerebellopontine angle cistern is an important space that contains cranial nerves 7 and 8, that is the facial and vestibulocochlear nerve, the fourth ventricle foramen of Luschka, the anterior inferior cerebellar artery, and some sources say the flocculus of the cerebellum. The Cerebellopontine angle cistern is a CSF-filled space. It is filled with cerebrospinal fluid, and it is positioned between the anterior aspect of the cerebellum and the lateral aspect of the pons, and hence comes the term Cerebellopontine angle. Next question: what is the most common Cerebellopontine angle mass? The answer I am looking for is that a vestibular schwannoma, which is also termed an acoustic neuroma, is the most common Cerebellopontine angle mass. Vestibular schwannomas account for something like 75% of all Cerebellopontine angle masses. Next question: what is the second most common Cerebellopontine angle mass? The answer I am looking for is that a meningioma is probably the second most common Cerebellopontine angle mass. I do think it is important for radiology board exams to keep things in mind, such as the most common tumor in a certain location. Even if they don't test you on that specific fact, just knowing that that is a most common tumor in that location increases the likelihood that you will be tested on Cerebellopontine angle masses that include vestibular schwannomas and meningiomas. And you need to know some hints that can help you differentiate between these as well as other Cerebellopontine angle masses. There are certainly additional Cerebellopontine angle masses, several of which I will discuss in this episode. Cerebellopontine angle masses you should be aware of include epidermoid and arachnoid cysts, ependymomas, and various metastases that include things like metastatic melanoma, as well as metastases from breast and lung cancer. And two entities that are certainly in the differential diagnosis of many different masses throughout the body, which are lymphoma and sarcoidosis. There are a few mnemonics that exist for Cerebellopontine angle masses. My personal favorite is probably the mnemonic Amen, A-M-E-N, not because it is religious in any way, but because it lists in order the four most common Cerebellopontine angle masses. So Amen, A-M-E-N. A is for acoustic neuroma, which is also termed vestibular schwannoma, and I already told you that that is the most common Cerebellopontine angle mass. The second most common mass, as you remember, is a meningioma, and that is the M in Amen. So A, acoustic neuroma, M, meningioma. The next most common mass is an ependymoma, which is the E, and then N for neuroepithelial cyst. And I don't love the N because it's a little bit of an indirect way to remember epidermoid and arachnoid cysts. So again, Amen, A, acoustic neuroma, M, meningioma, E, ependymoma, and N, neuroepithelial cysts. which are epidermoid and arachnoid cysts. There is another more complete mnemonic in terms of listing more entities, and that is angles, A-N-G-L-E-S. Again, A for acoustic neuroma. You could also add aneurysm and arachnoid cyst there if you like. N, and the part of this mnemonic is that N is close to M. I don't love that, but nonetheless, N, remember, is close to M, and then remember meningioma and metastatic disease. G for glioma, L for lymphoma, E for epidermoid cyst and ependymoma, and finally S for schwannoma. And that brings us to the next question. If you are shown a case with bilateral vestibular schwannomas, what underlying condition should you recognize on a board exam? The answer I am looking for is neurofibromatosis type 2. Bilateral vestibular schwannomas are a characteristic feature of neurofibromatosis type 2, and I believe I have released previously episodes specific to neurofibromatosis. Go ahead and check those out if you haven't listened to those episodes yet. Next, what are classic features of a vestibular schwannoma on imaging? On imaging, a vestibular schwannoma appears as a solid enhancing mass with intracanalicular extension that causes widening of the porous acousticus. I could have made a separate question about what the porous acousticus is, and I will actually give you 3 seconds to think about that. What is the porous acousticus? The answer is that the porous acousticus is the medial aspect of the opening of the internal acoustic canal. It's the medial opening of the internal acoustic canal. This is a key feature in terms of widening of the porous acousticus being a key that can help confirm that a mass is indeed a vestibular schwannoma instead of a meningioma. A meningioma does not classically extend into the internal acoustic meatus, whereas a vestibular schwannoma classically does do this and classically causes the characteristic porous acousticus widening. A meningioma, on the other hand, is more likely to cause hyperostosis of the adjacent bone in comparison to a vestibular schwannoma. Next question. If you are shown a cerebellopontine angle mass that demonstrates cerebrospinal fluid density, what are the top 2 differential considerations on board exams? The answer I am looking for is that cerebellopontine angle masses that demonstrate CSF density should make you think of an epidermoid cyst and an arachnoid cyst. And that leads us to the next question. What are some imaging features that can help differentiate between an epidermoid cyst and an arachnoid cyst? To differentiate between an epidermoid cyst and an arachnoid cyst, MRI is often of great value, and the key sequences on MRI that can help distinguish between an epidermoid cyst and an arachnoid cyst are diffusion-weighted images and the ADC map. An epidermoid cyst will show restricted diffusion and is characteristically very bright on DWI sequences, and will look similar to brain parenchyma on ADC sequences. On the other hand, arachnoid cysts will not show this characteristic hypertensity on DWI that you would expect to see with an epidermoid cyst. Other MRI sequences may show similar imaging characteristics between an epidermoid and an arachnoid cyst. As previously stated, both epidermoid and arachnoid cysts can demonstrate CSF density on CT imaging. Remember that epidermoid cysts are stated to be the 3rd most common cerebellopontine angle mass. That was the E in Amen mnemonic, and about half of all epidermoid cysts will be located at the cerebellopontine angle. Next question. If you see a cerebellopontine angle mass on CT that shows internal fat density, what is the leading consideration for radiology board exams? The answer I am looking for here is that a mass on CT in the cerebellopontine angle that shows internal fat density should cause you to consider a cerebellopontine angle dermoid cyst. Dermoid cysts are fat density masses that may show peripheral enhancement and calcifications peripherally. A classic imaging appearance you should be familiar with for radiology board exams is the ruptured intracranial dermoid cyst, wherein you would expect to see scattered fat density material that is typically scattered throughout the subarachnoid spaces, including the spaces between sulci and within the intraventricular fluid itself. If an intracranial dermoid cyst ruptures, this can sometimes cause a chemical meningitis, and that can sometimes be symptomatic. The chemical meningitis could manifest on imaging with peel enhancement along the surface of the brain. Go ahead and listen to that again because that is high yield for radiology board exams. You first of all need to realize that a mass at the cerebellopontine angle that contains fat density would be most characteristic for a dermoid cyst. Those dermoid cysts can rupture at times and scatter that fat density material throughout the subarachnoid spaces, and sometimes that can cause a chemical meningitis that can also be suggested on imaging based on peel enhancement. Next, what are some imaging features that can help distinguish a cerebellopontine angle lipoma from a cerebellopontine angle dermoid cyst? The answer I am looking for is that an intracranial dermoid cyst may not follow fat density on all sequences on MRI, but signal characteristics can vary. On the other hand, a pure fat-containing intracranial mass on MRI that follows fat density on all sequences would be more suggestive of an intracranial lipoma, a T1 hyperintense mass that fully saturates with fat suppression is more likely to be a lipoma versus a dermoid cyst. A cerebellopontine angle lipoma often surrounds and can contain internally cranial nerves 7 and 8. Next question. What is a vascular anomaly that can present as a cerebellopontine angle mass? The answer here is a thrombosed berry aneurysm. Remember that a thrombosed aneurysm can appear as a solid mass with only mild peripheral or mild internal enhancement. If the aneurysm is near completely thrombosed, thrombosed aneurysms are in the differential diagnosis of cerebellopontine angle masses. Sometimes thrombosed aneurysms can demonstrate a calcified rim on CT, and you would expect to see hemosiderin signal on MRI. Final question for this episode. Besides a vestibular schwannoma, what are two additional schwannomas that can occur in the cerebellopontine angle? The answer I am looking for is that beyond vestibular schwannomas, within the cerebellopontine angle, one can also see trigeminal schwannomas as well as facial nerve schwannomas. Although by far the most common cerebellopontine angle mass, whether schwannoma or otherwise, is a vestibular schwannoma. That concludes this episode. I hope that this review was helpful for many of you. Remember to download the free study guide on this topic if that is helpful for you at theradiologyreview.com. If you have episode topic suggestions for future podcast episodes, please email me at theradiologyreview@gmail.com or contact me on Twitter or Instagram at radrevpodcast. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.